public health, and not just in law and
Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Stephen Lin from Stanford Healthcare AI Applied Research Team about humanity and health in the age of AI. Let's get started.
Dr. Dan, hello, how are you doing?
I'm good, Faisel. Good to see you again.
It's great to see you. And Dr. Lin, welcome. Thank you so much for joining us today.
Oh, thanks for inviting me. Dr. Faisel, Dr. Dan, nice to see both of you.
Our primary audience are students, residents, people who are passionate about value-based care, and your career trajectory has been so impressive. I wanted to know, you've had so much, chief of general primary care at Stanford, and now all this work that you've done, amazing work with AI research. What inspired you to pursue this career in primary care and also all this innovation with health technology?
Yeah, thanks. Well, I think, like a lot of folks who choose family medicine as a career, I get bored really easily and I want to do everything. So that was really the reason why I got started in the space. When I was in medical school, I remember sort of just being in love with every single class I took and trying to reflect on the kind of doctor that I want to be. And to me, the family physician who takes care of everyone from children and babies all the way to elderly patients, men, women, caring for their communities, caring for entire families. That was the definition of what being a doctor meant to me. And I kind of got bored really quickly as I went from organ system to organ system. And I realized, hey, wouldn't it be cool if I could just choose whatever I want to do and really get involved with medicine at large. And so I was the only one actually in my class at Stanford to choose family medicine. You might imagine that primary care is not a very popular specialty in a large coronary care center like Stanford, but I've never regretted that decision. And the flexibility of being a primary care doc, being able to choose what you want to focus on, to care for the greatest breadth of people, that's what I love so much about my job.
It's interesting that you bring that up. I've recently returned to an academic position at the University of Virginia, and I was setting in on emergency medicine grand rounds this week, and they had somebody talking about corporatization of healthcare, how that's adversely impacted the emergency medicine. And when you think about it, I remembered one of my attendings when I was a resident that said, family medicine was the only specialty you could practice without electricity if you needed to. You know how to do a physical exam. And I was thinking about it would be tough to be an emergency medicine doctor and not having an emergency room, right? And all of those things. But we're seeing family medicine doctors who are able to remake themselves to do. They might work in academics, they might work for a private group, they might do direct primary care. It's interesting that our ability to recreate ourselves is just phenomenal, don't you think?
Oh, I couldn't agree more. When your denominator is everything, you can choose whatever it is you want to do. And Dr. Faisel, you mentioned sort of how my career took different turns. And I don't think I ever planned when I was a medical student or a resident, or even as an earlier faculty member, I didn't plan my path. I sort of just walked through whatever door was open for me. Oh, this looks interesting. I'll try this. Or I think this needs more attention and nobody's kind of really paying attention to it. I'll dip my toes in that. And that's what's so exciting about this field. And when I talk to students and residents who are even remotely interested in primary care, I say, yeah, there are a lot of issues to think about. It's a very difficult profession, but it's a very noble one and a very rewarding one, and ultimately the one with the most amount of freedom.
Do you think it was because of being a family doctor that it got you into all the AI research?
It was. I'll tell you a little story about it. I started down this path almost, 10 years ago, and I was the medical director of our large faculty primary care practice, family medicine clinic at Stanford. And it was a really tough time. And many of my colleagues were leaving our clinic, leaving Stanford, leaving the profession altogether because of burnout, too much documentation, too much stress. Patients were increasingly complex with little time to care for them. All of the stuff that you all know so much about. And I didn't know what to do. And at that time, AI was just starting to reemerge as a topic. Google, of all organizations, reached out to me and wanted to see if I wanted to collaborate on a project to create a digital scribe. This was like the very first AI automated documentation assistant before all of the products that are now on the market. And I said, I know nothing about AI. I've never taken a computer science class, never coded anything in my life, but
Oh my gosh.
if this is something that's going to help my colleagues, help people from leaving, help students and residents think about family medicine as a viable specialty to go into, I'm all in for it. And so we did this incredible project over the course of 2 years and really building out the first prototype of what is now today, your very fancy digital scribe. And that was my first foray into artificial intelligence. And I started thinking about, wow, if AI can do that, what else can AI do? What are some other primary care challenges or healthcare challenges at large that we can really point AI towards? And so I started this Stanford Healthcare AI Applied Research Team, or HEART for short, which is now one of the nation's leading primary care focused AI ML implementation science center, focusing on AI for primary care, built by primary care.
How are you teaching people how to use AI? I know there was a recent article, I think in JAMA Open, about that doctors by themselves did better than doctors with AI with chat. I think it was Chat GPT. I'm not sure which AI platform was used, but the AI platform alone did better than either one. And I've got to think the question is how do we learn? You've got to learn how to ask the right questions to get the answers right. I mean, I think it's just a matter of time. It's growing so quickly that it's going to be an incredibly useful tool. But how do we encourage learners to dig into it and then help them take better care of the patients that they're working with?
I love that question, Dr. Dan. And I think there's at least two parts to it, which is how do we prepare the workforce to think about AI? But then the other piece of it is all of this stuff that you hear in the media about AI versus doctors, how useful is that? And, how much should we put our trust in that stuff? Maybe I'll address the first. I think, so there's certainly stuff that we need to think about as a discipline about how to teach our next generation or even the current workforce on how to use AI. But I would say an equally important piece of it is how are the developers designing these tools in the first place? Ideally, they would design it in a way where it's incredibly intuitive for all of us to pick up. It should not require all that much training for us to learn how to use these tools. And if it does, if there's a lot of friction in that, they probably designed it wrong. And they probably need primary care docs at the table to teach them how to design their tools better for us. So that's number one. The training piece is really interesting because we know from a lot of studies that more than 90% of medical students across all disciplines, residents across all disciplines, and working docs across all specialties want to learn how to use AI better. And so there's a real dearth of resources out there. And that's why professional organizations like the Society of Teachers of Family Medicine, the American Academy of Family Medicine are focusing on creating new educational content to reach out to these folks. But the training space is really crowded. So if you look at UME and GME, where are you going to fit all this curricula? That's stuff that we still need to work out as a community. But to your second point, I hate it when people talk about AI versus doctors and, AI is better than, whatever doctor in whatever field in diagnosing whatever condition or anything like that. And sure, in very narrow tasks, there are certain things that AI will do better than humans because those are functions that are inherently to the advantage of machines. But what will never be replaced, my opinion, is the human interaction that's needed at the core of healing. And that's what primary care doctors do. It's that relationship-centered care. How much of our time is actually spent in diagnosis versus actual management or clinical decision making, in terms of shared decision making support with the patients. It's not as important, I think, for the primary care doc to get at a label of, oh, this is your diagnosis, but to really work dynamically with the patient. This is your understanding of the disease. This is what we think it is. This is how we're going to manage you in the long term. All of that stuff is not something that a machine is necessarily good at, much less sort of the relation-centered piece. And so what I always tell medical students and residents and faculty who are interested in this is, don't be afraid of AI taking over the job of physicians in general, but definitely don't be afraid of AI taking over the job of a family physician. Because for a relationship-centered specialty such as ourselves, we are going to be the last specialty that should feel threatened about the advent of AI. Rather, I think we're going to see AI take away some of our burdensome work so that we could actually focus on the patient in front of us.
I love that so much because it is, I mean, and even what we're trying to push for, to move away from the transactional model towards one that's based on relationships. I mean, it reminds me of a conversation I had. My dad, he sadly passed away last year, but he was an inventor. And so he had over 20 patents, and one of his patents was DTMF recognition, dual tone modular frequency, right? So if you push in a number 1 on a telephone anywhere, it's the same 2 tones pop up on the oscilloscope. He said, we've got these 2 tones, we can process that signal. And in his mind at the time, he was thinking that, you could enter in a code and have a synthesized voice let him know how much money he had available in his checking account, because he couldn't balance a checkbook. He was not that person. And he had no idea. And there was a lot of concern. Well, people got to call the bank and speak with people, and there are people who have these jobs. And if you end up having the computers just spit out information that people would, what jobs are going to have? And he said, oh, don't worry, new jobs will come. And the same thing happened and I feel the same with what you're saying. When I heard you speaking about the application of AI in medicine, it's the same. Same's going to happen. New jobs will be created. We're going to get rid of all these things, all the things that are driving people crazy now. Right?
That's right. Yeah, and it doesn't mean that I'm definitely not saying that AI is going to solve all of our problems, and I absolutely recognize some of the dangers of AI, and so it's pretty widely recognized that there is a lot of risk for bias and inequities with regards to algorithmic bias and things like that. We definitely need to focus on that. And actually, more the reason that primary care doctors should get involved and engage in this space in order to guide developers in the right direction, because we're so close with our patients, our communities, and we deal with issues of health equity day in and day out. So that's why I really encourage family docs to be at the table.
I mean, it just, from what you're saying, we're the ones who should be the ones who are transforming the healthcare system.
Absolutely.
You founded the O'Connor Stanford Leaders in Education Residency Program. So there's a lot of lessons that you could help impart to the next generation of primary care doctors. But what's the most important lesson for you for this new generation of doctors?
It goes back to what you were saying, a word that you just used, Dr. Faisel, which is transactional versus relational. What I'm seeing right now in this sort of current generation of medical students and residents that are coming into the workforce is a sense of sort of dissatisfaction with where the medical field is moving in general. And in their ideal mind, medicine should be a relationship-centered social endeavor. But more and more, because of the constraints imposed by the system, because of insurance companies, because of the way that our visits are structured, because of all of these things, the way that medicine actually is practiced in real life is highly transactional. And that transactional nature of medicine takes away the joy of why they wanted to go into this field in the first place. And a lot of practicing docs who have been doing this for 10, 20 years feel that moral injury. And that's what I'm really concerned about in terms of the state of medicine. And it's actually a difficult question that you ask. How do we instill hope in this new generation when we ourselves don't have much of it? And to be honest, that's part of why I chose to engage in things like AI, because it gives me hope to think about how we can really influence the field and move the field in a better direction. How can AI help us think more intentionally about population health rather than these sort of episodic, synchronous sort of visits that still underpin the vast majority of our healthcare encounters? How do we move from that to more of the continuous, asynchronously powered, digitally supported healthcare ecosystem that the doctors and patients really want? How do we deal with value-based care finally and move away from the fee-for-service world by using AI tools that help us figure out which patients are at highest risk of ending up in an ED and preventing that before it even happens, or figuring out these tools that allow us to deliver the right social, not just medical, but social resources to folks who need it the most. So I'm excited about the possibility of technology moving us in that direction towards that better future. And that gives me hope. That's why I do that work. And that's what I tell medical students and residents when they're feeling really pessimistic about the state of the world.
When I went to medical school, it was about who could memorize the most, the fastest. That's the people who did the best in their class. And now that suddenly it's sort of like what spreadsheets did for calculate. You don't see anybody walking around with a slide rule anymore. We don't have to be a walking compendium of knowledge anymore. But as you pointed out, we have to be able to interact with patients and figure out what of that knowledge they want to act on, and then how do we coach them to act on it rather than just coming up with the answer is the beginning, not the end. And suddenly the beginning is much easier, but then we take on more of a role coaching with them. And doesn't that really makes the traditional family doctor who's sitting down with the patient that much more important, doesn't it?
Couldn't agree more. That was so well said. The way I think about it is computers help us with the knowledge and analysis, and it's our job as human beings to wrap that with compassion and love.
I'd like to follow up with that. When I talk with the students and the residents, they want to know about some of the promising applications, some of the near-term applications that you see coming out with AI that could, something tangible that can help transform primary care practices. They're hearing about the ambient AI, but they're not seeing that in their, in their continuity clinics and stuff like that.
Yeah, absolutely. And actually, there was a large environmental scan report that came out around sort of which hospitals and where are we using AI already. And it's actually more than 52% of all hospitals and health systems in the US are already deployed have already deployed AI in a clinical setting. And so that comment about, we haven't seen it is going to be less and less over the next couple of months. And this is happening really, really quickly. But yes, there are so many potential use cases for AI, especially in the primary care and population health space. I kind of simplify it by bucketing it into three big categories. One is around sort of administrative burden reduction, how to sort of help us get through our day a little bit more efficiently and help us with some of our pain points in clinic. One is around sort of diagnostic decision support, helping us make better clinical decisions. I sort of think about these applications as being at the bedside, sort of in a one-on-one interaction between the doc and the patient. And then the third and big bucket is around how do we think about population health, not the one-on-one, but entire panels or huge populations or entire communities that we are accountable for. And then how do we enable accountable care and value-based care with these tools? So those are kind of the three big buckets. Right now, a lot of it is happening in the first bucket with the administrative burden reduction. So some of the more widely established and deployed products are in that space. So the AI scribe thing is one of those things. We have at Stanford a large language model powered draft auto reply system for patient messages. So when we get a patient electronic message, an AI automatically drafts a response to the patient for us that we can edit and send back. And it's not just drafting a response based on the message. It actually pulls their labs and radiology and past medical history from the EHR itself. So the response is tailored and personalized for that individual. And those applications Those applications have been incredibly helpful in terms of reducing cognitive load, reduce burnout, because if you ask any practicing doc, what are their top 2 pain points? They're going to say in basket and charting, right? So we're going to see that sort of be widely deployed first because that's already out there. And it's in many ways a relatively low risk application of AI to start. And that's a good place to start building trust and comfort with these systems. With the diagnostic decision support, there's already so many across dermatology, cardiology, neurology. Some of them are image based. So, now an AI runs in the background for every X-ray, every mammogram, every CT scan, and they can pick up findings that the radiologist can pick up. We have tools where you can take photos of skin lesions and give you a very accurate differential diagnosis of that skin lesion without a biopsy. It's a virtual biopsy, if you will. And that allows the primary care doc to do a lot of stuff without referring to the dermatologist, for example. These are just some of the examples of that sort of one-on-one clinical decision support. One of the cool things is that there's so much medical knowledge now. Decades ago, it took a long time for medical knowledge to expand and double. But now the doubling rate of medical knowledge is something on the order of weeks to months, not decades. And so how do we even keep up with that rapid growth? That's where AI can really come into play and help us deliver the most up-to-date evidence-based recommendations, help us think about guideline-directed medical therapy for everything from CHF to hypertension to diabetes. All of these, I think, are helpful to optimize the care of the patient at the bedside. And then that third bucket, I'm really excited about the third bucket because I think it goes to the heart of primary care, which is managing populations, caring about entire communities. So detecting and predicting when patients will actually end up in the ER, preventing that patient from getting to the ER before it happens, finding out which patients are at the most highest level of risk in terms of, social determinants of health risk factors and delivering the right, not just medical, but social support for those patients, transportation, food, all of that stuff. There's obviously AI can do things like language interpretation, it's like that Star Trek tricorder thing, that can automatically, like universal translator now, you tap your badge and you can certainly, you can talk in real time to anybody, anywhere. We can do that now, which is really cool from an equity standpoint. And so I think it's just really incredible the way that technology has advanced, and it allows us to do a lot of things we couldn't before and allows us to take better care of our patients. And I think primary care should be at the forefront for all of this because they really need us. The technology developers, a lot of them have very good intentions, but they don't understand medicine like we do. The specialists are great. I have many specialist colleagues, but their perspective of healthcare is limited to their specialty. Our perspective is everything. So we need to be at the table to really help advance this space.
It's the family doctor, especially with patient information. We're the ones who, the patient will they're walking out of the room and then the kind of, we're walking out of the room and as we have the hand on the doorknob, oh, by the way. And then you have the, oh, by the way conversation where they're like, I don't want this in the record, but, this is the special things that happen between doctors and patients. I feel it's probably going to fall on our shoulders too, to make sure that AI is used responsibly, especially when it concerns with patient information.
Absolutely.
Going back to the social equity, we've already had difficulty. I don't know in California, but at least in Virginia, in the patients that live in the rural areas versus the more urban areas, having access to broadband and being able to even do just telemedicine. And how do we keep that from getting amplified when we go into the AI world and keeping it from just being the haves getting access and the have-nots not having access? I'm
really concerned about that. And I'm so glad you asked that, Dr. Dan. There needs to be tremendous infrastructure support and investment in infrastructure support, especially in the rural parts of the country. It's not just broadband, it's also the rural hospital systems don't have the same human or IT infrastructure to enable some of these AI solutions. A lot of the large language models that we have right now are in English. And so the power of that automatic draft reply or ambient scribes and things like that largely exist in English language only. And so we need to challenge our technology colleagues in that industry to develop large language models for every language and think about investing in that space. And then, I'm also worried about just the inequities in having a say in what problems to tackle. And so if you look at the distribution of AI activity and investment, it's, of course, not surprisingly, heavily concentrated on the coasts in the large metropolitan areas. A lot of it is in large academic medical centers. So we're very, very lucky at Stanford to have the resources to do that, but not everybody does. And so how do we get this technology to the back streets of America so that every single person can have access to it? That's going to be something that will require, I think, multi-sectoral collaboration, government, industry, academia, and a political will to invest in that kind of infrastructure.
Okay, let me ask you a future prediction question. Okay, it's 2024. We're about to get into 2025. CMS wants everyone to be in an accountable relationship by 2030. It's a pretty lofty goal.
Yeah.
But after talking to you, I feel like it's attainable. So where do you see where AI will be, especially with how it'll shift the dynamic currently with patients and the healthcare delivery system? We're getting into 2025 now. In 2030, 5 years from now?
I think that the development of AI tools, I think it will evolve in parallel with this evolution of fee-for-service to value-based care, just in terms of how do you even pay for the use of these tools? A lot of the early tools, you can come up with CPT codes for very narrow, I use this tool to make this diagnosis type things. But that is not a sustainable way to really pay for the use of these tools. What is really going to be helpful are those tools, like I mentioned before, looking at an entire population, predicting those at highest risk, and dedicating resources to prevent bad things from happening, right, to them. And guess what? That saves the system money. That decreases total cost of care, increases quality. That has to be used in a value-based care setting. And you can't generate single CPT codes for the use of that tool for every single patient. That's sort of a situational awareness AI that's always on, right? That's always caring for our public health or in our patient populations or in communities. And so the only way that those tools are going to really be unleashed, the power of these tools be unleashed, is if it's happening in a value-based care or accountable care setting. So I think the success of a lot of these AI tools will also depend on our ability in parallel to move towards that value-based care world. And precisely that is why we need to be driving this, because the whole movement towards value-based is largely a primary care-driven initiative. So we are actually well positioned because of this natural parallel evolution of this technology and this reimbursement model to drive that conversation forward.
If you got a doctor who's listening right now and he's like, Dr. Lin, you got me. Okay, what are the next steps I can take to integrate AI or, anything that we've been talking about into my practice?
I would say, first of all, don't be scared. Don't be scared to try it. I have no AI background myself, right? Like I was telling you, I just knew it was important for me to engage and for me to learn. And so there are going to be resources that will be offered by our professional societies in our discipline that can be helpful. But the biggest thing is just not to be intimidated and start trying things out. Today, you have very accessible AI tools that anybody can download for free, actually, and start using. OpenAI's GPT that is very, very popular, Google's Gemini, not to just mention those two, but there's, 24 other large language models and AI companies that can offer that. Start playing with it. Start figuring out how it can be helpful for you in your daily life, in your daily work. And if the opportunity comes up to try something in your practice that could potentially address one of your pain points, be it AI documentation tools or AI draft responses for your My Health messages, those things that are really suffocating you and your practice right now, don't be afraid to give that a try. Give it a try. And you'll be, the number one feedback that I hear is, I had no idea it was this good. Had I known it was this good, I would have tried it earlier. I totally understand the hesitancy, right? Like, we were screwed over by the EHR deployment. And so there's a lot of, I'm not going to get screwed over again. I don't want to be an early adopter. Let me wait and see, how things go. And I will say it's good enough for you to try right now. And I think you'll be pleasantly surprised at what it can do. And then just start playing with it and exploring with it. Dip your toes in it. And eventually it will get less scary and less scary. And then you can make your own decisions about how you want to incorporate that into your practice.
Dr. Lin, thank you so much for taking the time out of your busy schedule to join us today and answer our questions. And I'm excited. We're going to have to revisit this sooner than 5 years from now.
Sounds good.
But I will reach out to you 5 years from now.
Will do. Well, thank you, Dr. Faisel. Thank you, Dr. Dan. Appreciate it. Honored to be here. And looking forward to future conversations.
Absolutely. Thank you.
What are your thoughts on humanity and health in the age of AI? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.